Hello, I'll be talking about hypogonadism and focusing on the workup of hypogonadism and then the therapies. And this will be about 15 minutes, and I do have one question in this short presentation. Okay, no disclosures. So all endocrine talks usually have to have some kind of axis, and it is important here. So you have the hypothalamus and then the pituitary glands, and I'll see if I can quickly get a pointer. And then the luteinizing hormone from the pituitary gland talks to the testes, which then go on to make testosterone. Okay. Next slide. So the definition of hypogonadism. So it's men with signs and symptoms of testosterone deficiency, and then unequivocally and consistently low morning serum total testosterone and or free testosterone. And then a quick little note here that testosterone may be suppressed by food intake, so you may want to have your patients have these labs done fasting. So I have a few slides here on specific symptoms and signs, suggestive, and then not specific. And so we'll just go through those. So this first slide is more specific, and these are things that I don't see as often or hear about as often as the coming slides. So one is a patient with incomplete or delayed sexual development. Another more specific symptom and sign is loss of body hair. So axillary and pubic maybe more than other sites. And then very small testes, so less than 6 mLs. And a normal testes is about 15 to 20 mLs. So it's quite a bit smaller than normal. Suggestive symptoms and signs. So these are now probably more things that we hear about on a day-to-day basis. And then so patients will have reduced sexual desire, libido, and activity, erectile dysfunction. They could have breast discomfort or gynecomastia, inability to have children. So they were found to have a low or zero sperm count. They have low bone densities, or they could be complaining of hot flushes and sweats. So the non-specific symptoms and signs associated with testosterone deficiency are decreased energy and motivation. So people will want their testosterone checked for this reason. Feeling sad or blue, depression, poor concentration and memory, sleep disturbance, so they feel more tired, and again this can connect back to a decrease in energy and motivation, mild anemia, reduced muscle bulk and strength. So you'll hear men that go to the gym and they just can't see the results that they want to, and then increased body fat, BMI. So another story is that men are not able to lose weight like they think they should be. So the Endocrine Society states that clinicians need to use accurate and reliable methods, and ideally a testosterone assay that has been certified by a quality control program. So wherever you end up practicing, you need to look into where labs are done and how they're done. And so the suggestion is that total testosterone should be measured by a technique called liquid chromatography mass spectrometry, or the abbreviation is LCMS. And this is more accurate at low concentrations. So this is just a slide that shows different orders. And again, I'll bring back my pointer here. And so in our institution, we can find an order that has total testosterone, both free and, so testosterone, both free and total. And you can see that it's done by LCMS. So this is usually what I do when I'm trying to diagnose someone with hypogonadism. I'll try to get the most accurate way of measuring testosterone. And this is actually sent out, and it is done by a reference laboratory. Okay, next slide. So here is a illustration of the different components of testosterone. So we have the total testosterone, and that is testosterone bound to sex hormone binding globulin, which is a protein. And then it also measures free testosterone, which is the least, it's unbound, it's free, it's the lowest amount of testosterone in the male body. And I've seen, anywhere from about like 2 to 4% of testosterone is actually free testosterone. And then another measure of testosterone is that bound to albumin. And so free testosterone and testosterone bound to albumin is called bioavailable testosterone. So some of these testosterone panels, you can also get bioavailable testosterone. And then, so SHBG, so testosterone bound to SHBG is probably the most common form, but SHBG can sometimes be higher than normal or lower than normal. And the table on the bottom right here gives us all different conditions that cause high SHBG or low SHBG. So I'll just go through them because they're worth saying out loud. So aging can cause high SHBG, chronic infection like HIV, hyperthyroidism, which no endocrinologist wants to miss, elevated estrogen, so we could see this in advanced liver diseases. So example is like PBC, alcohol consumption, medications. So in the endocrine world, we could have patients on pioglitazone, for example. You could have a patient on anticonvulsants. Just for knowledge purposes, oral contraception in females is going to raise SHBG, and this is one of the reasons that oral contraception can be good for hirsutism because it binds up more free testosterone. SHBG polymorphism, so people can just be born with higher SHBGs, and then extreme weight loss. Low SHBG can be caused by obesity, so we see this often. Diabetes and insulin resistant states, hypothyroidism, again, not relevant to the male, but PCOS, we can see lower SHBGs, medications like steroids, and then when someone's taking androgens, they can have lower SHBG. Again, SHBG polymorphisms, nephrotic syndrome, and then acromegaly. So this is a slide kind of bringing you into the clinic space, and you screen someone for hypogonadism, you get back your panel, and just to highlight a few things, so you get back a number which is 145. It was done in the morning, which is good. And then the reference interval does look like it's pretty appropriate. So the lower limit of normal is 300 on this assay. The SHBG you can see actually is at the lower end of normal. So then free testosterone and bioavailable testosterone may be helpful. And both of these components are low, so everything is in line with each other. So how do you actually go about diagnosing hypogonadism? So this is from the Endocrine Society guidelines. And so just like in the other slide, you measure your morning and maybe ideally fasting testosterone. And the guidelines do say to measure free testosterone if SHBG is altered or total testosterone is borderline. And I would say more common than not, we live in an obesity epidemic. There's usually a reason that SHBG could be altered. So I typically get it. And I also, again, get that panel that has the free testosterone plus or minus the bioavailable. So really important is you do need to confirm that the testosterone is low. So you need to get another sample separated in time, and I would say at least 2 weeks. It needs to be done in the morning because, again, that's when testosterone should be at its highest. And so if you confirm that someone has low testosterone, then the diagnosis is confirmed. It could probably change over time depending on what the cause is. But the most important thing that I want to say is that you should measure the gonadotropin. So luteinizing hormone is important. So I wouldn't just start treating someone right away after you've gotten these testosterones. I think you need to figure out whether you're working with secondary hypogonadism or primary hypogonadism. So we'll start here on the right. And so primary hypogonadism is when luteinizing hormone actually comes back high and testosterone is low. And so the problem is at the level of the testes. And the one thing that you need to check for is Klinefelter. And one of the statistics I have heard is about 1 in every 500 men could have this condition. So ordering a karyotype is very appropriate here. Just to see if they're XXY. And then more common than not, so luteinizing hormone is going to be low or inappropriately normal. And then you're going to look for a bunch of other reasons that can cause secondary hypogonadism. And the next slide will go through that a little bit more. So I'll just go over to it. Okay, so causes of low testosterone. So how about we start with the secondary hypogonadism, the more common version that we see. And so organic causes, there could be a tumor in the hypothalamic or pituitary region that's preventing the luteinizing hormone or the region of the brain to respond to low testosterone. We don't usually do an MRI unless the total testosterone is at least less than 150, so pretty significant. But of course, if there's any kind of clinical reason to do it, you should use your good clinical judgment. Hemochromatosis can also cause secondary hypogonadism. So we need to look at iron panels, and specifically you want to look at the percent transferrin, and screening would be greater than 45%. And this happens. So we do catch hemochromatosis. It's kind of interesting lately. I haven't really caught, I've caught some heterozygous. So, I guess there's a question whether that really is contributing to anything. So infiltrative or destructive diseases, again, this is like anatomic at the level of the hypothalamus pituitary. And then this also happens every now and again where you have a case of congenital hypogonadotropic hypogonadism. And somehow, sometimes it comes up from children's, but sometimes these guys are missed in peds, and we end up diagnosing them when they're looking for fertility. So there are functional reasons for secondary hypogonadism, and these are things that we're checking for in the clinic, and these are reversible causes potentially. So hyperprolactinemia is big. So when you have secondary hypogonadism, you need to look for too much prolactin. You also need to look for hypothyroidism. Opioids are big, and opioids can actually cause pretty significant hypogonadism, like double digits. Anabolic steroid use, steroids, alcohol, marijuana use, maybe systemic illness could cause secondary hypogonadism. Nutritional deficiency, obesity for sure, we see a lot. And then I'll flip over to primary hypogonadism. So again, I said Klinefelter syndrome. You do need to look for that if you find primary hypogonadism. And then also on the clinical history, if someone has cryptorchidism, cancer chemotherapy, testicular radiation damage, any kind of, incident to the testy could explain this. And then I really haven't seen functional causes of primary hypogonadism, but I suppose they may exist. So some medications that I'm not familiar with, and an organ failure, may cause a functional primary hypogonadism. Okay. So the next couple slides are a question to get you into the clinic and get you thinking. Okay. So which of the following is the most likely diagnosis? Covert anabolic steroid use, pituitary adenoma, hemochromatosis, functional hypogonadotropic hypogonadism, and celiac disease. Okay, so you have a 26-year-old amateur runner presenting with fatigue and declining race performance. Over the last 4 months, he scaled up his training program in preparation for a marathon. He reports an intentional weight loss of 15.5 pounds, fatigue, reduced libido. He describes longstanding intermittent and minor abdominal bloating attributed to lactose intolerance. He underwent normal puberty. He is unsure about fertility as he has not attempted to achieve fatherhood. He does not use prescribed or illicit drugs except for infrequent use of NSAIDs. There is no history of head trauma. His BMI is 21. His blood pressure is good. His pulse is 50. There's no clinical visual field deficits. Muscle bulk is normal. Testes are normal at 25 mLs bilaterally. And here are labs. So his total testosterone's 55 and reference is 300 to 900. And then you repeat it, it's 66. You get some more labs. So his SHBG is a bit high. His LH is low. Also FSH is 0.7. Hemoglobin is a little bit low. Prolactin is 20, which is normal. Ferritin is a little bit elevated. Transferrin saturation is 35%. His thyroid is normal. And so going back to the answer choices, do you think that this patient has anabolic steroid use, a pituitary adenoma, hemochromatosis, functional hypogonadotropic hypogonadism, or celiac disease? So the answer is actually a functional hypogonadotropic hypogonadism, so secondary hypogonadism, and it's probably from this condition called RED-S, which is relative energy deficiency in sport. And a few points to highlight is the SHBG is probably elevated because of his excessive exercise and energy deficient state. He has mild anemia aligning with hypogonadism, so we see that. And then some pearls about the wrong answers. So covert anabolic steroid use appears as central or secondary hypogonadism, but the clinical picture is different for maybe the patient that they presented. And then SHBG may also have been lower if this were the case, and hemoglobin hematocrit may be higher. Okay, and so it looks like I can't believe that it's already been 20 minutes, so I'll kind of go through this fast. So testosterone replacement, there are different routes of administration. It looks like there's 5. So one of them is nasal. I hardly have ever used this because you do need to use the nasal preparation about 3 times a day, which is really hard for people to do. I think also people are not so into using a nasal spray as a route of administration in general. One of the marketing things about it is talked about as it might be like a more quicker acting testosterone. So people that are concerned about their fertility may consider nasal preparation. And one thing I didn't say is that testosterone replacement takes the sperm count down to 0. It's not a foolproof method, so it can't be used as contraception, but it certainly should not be used in someone that wants fertility. So a discussion needs to be had. And then subdermal testosterone. So the only brand that's on the market is Testapel. These are pellets that are inserted every 3 to 6 months. Gel and injectables are the most common forms of replacement. So gel is every day. And then injectables, you can use a vial and syringe, which is the cheapest method of replacement. And then there is also a pen. And there's only one brand on the market. It's called Zyosted with an X. And it comes in a single dose pen, so 50, 75, or 100 milligrams, and you don't see the needle, so it is good for people that have some kind of needle phobia. There's also a long-acting injectable called Aveed, and this is given every 10 weeks in the clinic. Also something to consider for someone that may be on testosterone for a long time, such as someone with Klinefelter syndrome. And then oral testosterone is on the market now. I think there are 3 companies that make an oral version, but the pills are generally bigger. They need to be taken multiple times a day. And you do not have to worry about liver toxicity. So this is not like preparations that were used in the past. So they are safe from that liver perspective. So I will end here. I hope that this has helped somewhat with the workup of hypogonadism and the therapies. Thank you.